Hello guys and welcome to my channel. Today we are going to have a discussion on the topic of volume of distribution of a drug. We will be covering our topic under the following headings. Let us take one heading at a time. The first thing that we have to understand is what do you mean by volume of distribution. Now the volume of distribution, it is a pharmacokinetic parameter, and basically the volume of distribution, it actually represents an individual drug's tendency to either remain within the plasma or redistribute itself to some other tissue compartment. Now this volume that we are talking about, it does not necessarily refer to an identifiable physiological volume. Why is it so? Because it is a fluid volume that we are calculating that would be required to contain all the drug that is present within the body at the same concentration at which it has been measured in the blood or in the plasma. Hence at times we also use the word apparent volume of distribution since it has been calculated. Now the definition for the volume of distribution, it basically states that it relates the amount of drug in the body to the concentration of drug in the blood or the plasma depending on the fluid that we are measuring. So if we denote the volume of distribution by V, then the amount of drug in the body divided by the concentration of drug in the blood or plasma is going to give you the volume of distribution. What are the general principles of drug distribution? Now the distribution, as we know, it basically refers to the movement of the drug. Now this movement of the drug is going to occur between two compartments. First is the intravascular compartment and the second is the extravascular compartment. Now the intravascular compartment is formed by the blood or by the plasma, as well as the extravascular compartment is formed by the intracellular or the extracellular components that we have got. Now within each compartment, be it the intravascular or the extravascular compartment, a drug will exist in equilibrium between two forms. The first is a protein bound form and the second one is a free form of the drug. The implication of the volume of distribution. Now a drug that will have a high volume of distribution, it means that the drug can be distributed very easily. So that drug is going to leave the plasma and then enter into the extravascular compartments of the body. Now since the drug is leaving the plasma and entering the extravascular compartments, hence a higher dose of the drug will be required to achieve a given plasma concentration. Now exactly opposite, if a drug has a low volume of distribution, that means it will not be distributed so easily. So that drug is going to remain in the plasma and hence a lower dose of the drug will be required to achieve a given plasma concentration. Let us see what are the compartments of drug distribution. So basically there can be two compartments of distribution of the drug. The first compartment is the central compartment. The central compartment is basically formed by the blood or the plasma or some of the highly perfused organs such as the liver, kidneys and brain. The second one is the peripheral compartment. The peripheral compartment is the one to which the tissues to which the drug is distributed very slowly, say the muscles. So immediately, suppose we are giving a drug by IV bolus, so immediately after the drug has been given as an IV bolus, obviously the drug will be given within the blood or the plasma only. So the drug will enter into the central compartment and later on some of the drugs, they may move from the central compartment to the peripheral compartment. So there are two models for the distribution of drug. The first is the single compartment model and the second one is the multi-compartment model. Now let us first see what is the single compartment model. Few drugs, they distribute instantaneously. So what we mean by that? That these drugs, they actually remain within the central compartment only, and they are not distributed to the peripheral compartments. Hence, the total drug is present within the central compartment. Suppose it is present within the blood. So if there is any major decline in the drug plasma concentration, then that is because the drug has been eliminated from the plasma only. Because the drug has not been distributed, so it will be eliminated from the plasma only. These kinds of drugs that display a single compartment model, if a kinetic graph is produced between the plasma concentration and the time, we are going to get a straight line graph. And since the drug is distributing itself very instantaneously, it is not possible to calculate the initial plasma concentration at time 0, because the distribution is occurring instantaneously, right? So if we have to estimate that graph, we have to extrapolate it to time 0 on the plasma concentration versus the time graph, right? So this is the graph. See, we have to extrapolate the graph to time 0, right? This part has been extrapolated to time 0 since there is instantaneous distribution of the drug. The second model is the multi-compartment model. Most of the drugs, they follow the multi-compartment model, in which the drug, they will initially move from the central compartment into the peripheral compartments before it has been eliminated. In the earlier model, we saw that the drug was present only in the central compartment, but in case of a multi-compartment model, the drug has been distributed from the central compartment to the peripheral compartment. So the phases of distribution for a multi-compartment model is that first is the distribution phase. So in the distribution phase, following the administration of the drug, the plasma concentration of the drug will initially decline, while the total amount of the drug in the body remains the same. Why is it happening? Because the drug, as I have already said, from the central compartment, the drug is going to the peripheral compartment. But there is no elimination of the drug. So only the distribution of the drug is taking place. That is why the plasma concentration is going to reduce, obviously, because of the distribution. But since no elimination is taking place, the total amount of the drug within the body will be same. Followed by that, there will be a terminal elimination phase. In that phase, after the drug has been distributed, now the drug will be eliminated from the central compartment. And this elimination will be done either by the kidneys or by the liver. Now, in this case, after the elimination phase, there will be changes in both the concentration of the drug in the body as well as in the plasma. Now, in between these two things, there will be a steady state. Now, the steady state of a drug represents the period of a dynamic equilibrium. Because in this steady state, the drug has completed its entire distribution between the central and the peripheral compartments. And since there is entire distribution, or there has been a completion of distribution, at steady state, the net flux of the drug between the central and the peripheral compartment, it will be 0. So there is no net movement of the drug between the central and the peripheral compartments. So this is the kind of a graph that we are going to get for a drug which is following the multi-compartment model of drug distribution. Let us now look at the various features which affect the volume of distribution of a drug. Now the first will be the acid-base characteristic of the drug. So for the drugs which are basic molecules or alkaline molecules, in general they will leave the systemic circulation, and hence there will be a higher volume of distribution as compared to the acidic molecules. Now the acidic molecules, they will be more likely they will be bound to albumin, and hence because they are bound to the albumin, they will remain within the plasma and there will be a lower volume of distribution. Now the second factor is lipophilicity. Now lipophilic molecules, obviously as we all know that lipophilic molecules will be more likely to pass the lipid bilayers, and since they can cross the lipid bilayers, they are more likely to leave the bloodstream, and if they leave the bloodstream, then they will distribute to areas which have got high lipid densities, right, because they are lipophilic molecules such as the adipose tissue. Now because of this entire thing, there will be a higher volume of distribution. On the other hand, if we have got the hydrophilic molecules, then they are less likely to pass through the lipid bilayers, and because of this they are more likely to remain within the bloodstream, and therefore they have a lower volume of distribution since the drug is remaining within the bloodstream. And hydrophilic molecules such as streptomycin and gentamicin, they have got a very low volume of distribution, right, only 0.25 liter per kg. The third point is the degree of the plasma protein binding. So now the drugs that are extensively bound to the plasma protein, there will be higher molecular weight compounds since they are bound to the plasma protein. Now this high molecular weight compound won't be able to cross the membrane so easily, hence they will be restricted to the vascular component only, and there will be a low volume of distribution. As we can see for warfarin, which is 99% bound to the plasma protein, the volume of distribution that we get is only 0.15 liter per kg. What is the clinical significance of volume of distribution? Please remember this point, that the single most important utility for calculating the volume of distribution is the calculation of the loading dose from it. So the loading dose of a drug is actually dependent on the volume of distribution. The maintenance dose of a drug is actually dependent on the clearance. Now the second point to note is, in case of poisoning, the drugs which have got a high volume of distribution, they are not easily removed by hemodialysis. Why is it so? Because the drugs that have got a high volume of distribution, they are actually present in the extravascular compartments, and hence removing them by hemodialysis will be difficult. Let us now understand the concept of redistribution. Now this redistribution is specifically seen for the drugs that are highly lipid soluble. So initially those drugs are distributed to the organs which have got a high blood flow, such as the brain. Later on, these drugs are distributed to the less vascular but more bulky tissues such as the muscles and the fat. Now due to this, the plasma concentration of the drug falls and the drug is withdrawn from the highly perfused sites. Now, if the site of action of the drug was in one of the highly perfused organs, then because of redistribution, there is termination of action because the drug has been redistributed from the highly perfused organs to organs that is less perfused. So the concentration of drug at the highly perfused organ will be lower. And if the site of action of the drug is in that highly perfused organ, then obviously there will be termination of action. This is seen in case of an IV anesthetic that is known as thiopental sodium. Thiopental sodium has got an action that is lasting within minutes, but this termination of action occurs because of its redistribution. So that's it for today, guys. The upcoming lecture we will be discussing about the loading dose of a drug. So if you like this video, then give it a thumbs up, subscribe to my channel, and please press the bell icon, and let me know down in the comments below what other topics you would like us to discuss.